Hi, I'm Dr. Rich Vogel. I'm a board-certified neurophysiologist, and I'm co-chair of the section on intraoperative neuromonitoring. Today I'm joined by my other co-chair, Dr. Adam Doan, who's also a neurophysiologist, and with orthopedic spine surgeon and past president of NAS, Dr. Todd Wetzel. And we're going to be talking about a topic that comes up often when we talk about the value or the utility of neuromonitoring, which is the therapeutic value. So that we know with the appropriate combination of test modalities in neuromonitoring that we're good at detecting changes in neurologic function. But then the next question is, can we apply therapeutic value by performing some form of intervention in order to restore those signals back to baseline and have the patient emerge from surgery with no deficit, or perhaps a deficit that is not as bad as it would have been otherwise. So we're going to run through some surgical scenarios and just get a sense from a surgeon's perspective where Dr. Wetzel has seen therapeutic value in the course of neuromonitoring. Adam, do you want to start with first scenario?
Sure. All right, so let's start in the lumbar spine. And you place a lumbar pedicle screw, you get a low value. Presumably that implies that maybe there's a medial breach. What sort of guidance or judgment do you use to determine if you're going to leave the screw in place, redirect the screw, or just remove it entirely?
Yeah, that's a good question to start, Adam. Obviously, if you're below the 10 milliamp threshold, you're going to go look at the screw. That's the first step. And you inspect the pedicle medial wall directly, look at the nerve root, where's the DRG, that sort of thing. If there are any threads showing, are they compressing anything, or are they likely to cause an inflammatory reaction? If you can determine that by direct inspection, and the answer is there isn't anything significant about the screw, you can let it in place, assuming you don't have a lateral breach, which could have accounted for the low impedance. If the screw is not accessible for direct inspection, meaning facetectomy, lateral recess decompression, direct inspection of the nerve root, then you remove the screw and the tract is explored. And if there are any breaches, that's a clinical judgment. Does that screw really need to be reinserted? Does it need to be redirected? Or can it be left out?
And what about a scenario, still sticking with lumbar spine surgery, you're doing a TLIF procedure and you place a graft and in this scenario, we're running motor evoked potentials to evaluate the various nerve roots. And immediately before you place the graft, everything is fine. Immediately after you place it, there's a significant deterioration in the motor evoked potential from the tibialis anterior muscle, suggesting the possibility of this patient waking up with a foot drop. So the question is, how do you proceed? Do you remove that graft? Do you perform visual inspection? How do you respond to that alert that's being communicated to you?
Yeah, I mean, the two salient issues there, Rich, are, again, is there anything compressing the nerve root, an osteophyte, a new fracture, graft malposition, or is this a neuropraxia? Now, of course, neuropraxia you wouldn't expect necessarily to show up that quickly. So again, direct inspection, and I personally have a very low threshold for removing the graft and either letting it out, changing the rate of fusion, or reinserting another graft. And then obviously the usual things, make sure MEP is about 90 millimeters of mercury, make sure the anesthesia is appropriate, and do everything to optimize the return of the signal. But I would have a very, very low threshold for removing that graft.
So what about for ALIFs? Typically, ALIFs are monitored with EMG and SSCPs,
right,
sometimes with motors as well, just depends. So if you're doing an ALIF and there's not going to be a posterior portion of the procedure, how do you perceive the value of neuromonitoring in just that procedure?
Yeah, I think SSEPs in an ALIF have the same utility they do in posterior surgery. Just as a general safety feature. The real key for an ALIF, though, are the EMGs, because typically what happens with L4 or L5, which is the 4551, which are the most common levels, is you see decreased H reflex, because that demonstrates there's S1 irritability. And I've had that experience many times with a large graft, and that's solved simply by repositioning the graft or replacing it with a lower one. And then the H reflex gets better and you know everything's okay. But for an ALIF in particular, I think the EMG is key.
Can I ask a follow-up question on that? So I would say that the average team out there is not monitoring each reflex on those procedures. And have you ever thought about using motor evoked potentials on ALIFs to sort of get that same sort of like motor type information?
Yeah, I have, and it really is just a question more of convenience than anything else. I think that would actually be an excellent investigational project to look at prospectively 10 EMT, 10 motors and 10 EMGs. So maybe I'll do that.
Yep.
So let's move into cervical spine surgery. I want to give you two different scenarios.
Okay.
Both of them are placing a graft at C4-5. So in scenario one, you place the graft, and prior to placement of the graft, motor evoked potentials are fine. SSPs are fine. After you place the graft, the only thing that's changed is your left deltoid motor response has gone down significantly. Let's just say it's absent or it's down 90%. How do you proceed there in terms of, do you remove the graft, do you elevate blood pressure, do you pause, retest?
Yeah. I think particularly when you're looking at cervical and thoracic, general principles include, one, don't ignore a change in the signal. And that leads to number two, that the likelihood of somebody either not having a neurologic deficit, having a neurologic deficit that will recover, or having a milder deficit is far higher if you intervene intraoperatively. And we'll be talking about that in the symposium this afternoon. There are a lot of data that demonstrate that. C5, as you know, because of the rather acute angle of the nerve exiting in the neural trunk, is particularly prone to a C5 palsy. We've seen this in laminoplasty, have certainly seen it in ACDFs. So absolutely, absolutely remove the graft. And that's, there's a temptation, when you're doing an interbody fusion, you really want to distract to the point of the ligament ataxis that it's giving you a nice posterior anchor. So there's kind of a natural surgical tendency, I think, to over-distract. And that C4-5 is particularly vulnerable to that. So the first thing I would do would be to remove the graft and wait and see what happened with the signal, assuming, again, blood pressure, anesthesia are changed.
Yeah, so that leads straight into what I was going to ask you. A lot of times we think about, bumping up the map when it's a spinal cord type of issue, but you said it in the lumbar spine and now the cervical spine. So if you had a change that was more indicative of a nerve root and the cord was fine, would you still optimize blood pressure, maybe bump it up a little bit higher than it was to see if you can hyperperfuse that?
Yeah, and really, and sorry to interrupt. Yeah, and really for no good reason. I mean, that that is important in the thoracic and the cervical spinal cord, but I think it's if you're concerned about that, it's why not do it? Because you may increase perfusion.
Yep.
So my second scenario was instead of there being an issue with a nerve root, place a C4-5 graft, you lose all motors and SSCPs below that level. Does that change how you treat that scenario? You're still removing the graft?
Yeah, I mean, first you have to revive the surgeon, but yeah, but yes, definitely remove the graft, and then. Again, that is a scenario where it's incredibly important to get the mean arterial pressure normalized and check the anesthesia. And, some of the literature, again, shows that in really situations like that, which are of grave concern, that if you act on it with the appropriate monitoring information, with the appropriate supportive information, the recovery rate is something like 3 or 4 times what it would be without that alert. Mm-hmm.
What are your thoughts on steroids? So, most surgeons are okay given like low dose, like a decadron or something like that. And things like Solumedrol, the steroid protocol, have become, I guess they've always been controversial, and that controversy is still out there. What are your thoughts on it? Yeah,
there really is no good reason to do the high-dose steroids, in my view, based on the literature. The history of the NACIS studies has always been controversial. I believe the American Academy of Neurosurgeons has officially recommended that they not be given in cases of spinal cord injury. And this is really an analogous situation. So, Solumedrol, fine for local perfusion, but really if you look at the morbidity and the mortality associated with the high-dose NASCAS protocols, I don't think many people do that anymore. Even there was kind of the last vestige from a medical legal point of view, but now since almost all the societies have come out and said that's not really helpful, I think we can listen to the data and hopefully not be swayed by these rather pervasive external influences.
Yeah.
Is there a situation, just following up on that question, is a situation where you'd be more likely to give that protocol, or is it versus less likely, or is it more the case that it just simply generally doesn't make sense to do that?
Yeah, I think it's the latter, Rich. It just really doesn't make sense. And, I don't really know of anybody who's doing it anymore. That's the ultimate and anecdotal, but I just don't, I'm not aware of it if people are still doing it.
So maybe to sum things up, I think a good question might be, like, all of these interventions that we just discussed, in your experience, have you had success with all of these? If you do see a change, there are actions that can be taken that can reverse the change and hopefully, pretend a good outcome.
Absolutely. Of course, the circumstances where there has been an unfortunate outcome tend to stick out in your mind a bit more, but fortunately, those are very, very small. Count them on one hand after 30 years. Actually, I can count them on two fingers. But absolutely, it's been incredibly invaluable. The other place where it's been invaluable is with tumor surgery. Did quite a lot of that when I was at the University of Chicago, and particularly in patients who'd been embolized pre-op, you need to get a good baseline signal to make sure they're not at risk before surgery, and that was just an incredibly valuable tool for that. Very valuable tool for fracture reduction, and really the standard of care. The other thing that I would put in a plug for are really judicious use are some of the more specialized things. For example, in a redo anterior cervical discectomy infusion, monitor the recurrent laryngeal nerve. Those things are very, very helpful. The circumstances where you use the brainstem auditory evoked responses, very, very helpful. So I think neuromonitoring is not only cost effective, but it adds a safety net that is just remarkable.
So it sounds like we've done a good job in the literature of demonstrating that there's diagnostic value. There's more room for us to demonstrate therapeutic value in the literature. But from a surgeon's perspective, you've certainly seen a lot of benefit in the therapeutic benefits of neuromonitoring to be able to intervene and reduce deficits.
Absolutely. And particularly, when I started, Harrington rods were the standard of instrumentation. That's long ago. And I remember wake-up tests. I remember when the evoked potentials came in. And when motors came in, seizure-free motors, it just revolutionized things, because the wake-up test was notoriously unreliable and had a tendency to be the get-up test. So that was not something you enjoyed doing.
Well, we thank you very much for taking the time to talk about your experiences with neuromonitoring and the therapeutic benefits. And to the audience out there, thank you for listening.
Great pleasure.
Thank you.
Thanks.